Well, it's always fun to be last. It's always intimidating to be at these events. I am not a doctor, I am a lawyer. Um, but what keeps me going are the patients. And I am always so inspired by the people who I fight in the trenches for every day. I don't see patients often, like the doctors do, or like many of the folks who do support services do, but it's so important to remember when you're in the trenches that there's a reason why you're fighting. And so I was so inspired today by you, and thank you for sharing your story. So lung cancer is a tough, tough disease. We do pictures, and while other folks have talked about it being the leading cause of cancer death, we always show the picture. And when I work on Capitol Hill, that always takes the breath away of staffers because they don't realize the impact of this disease. And one of the things that's so disappointing about it, folks not understanding this, is that they also don't understand that 60% of the people diagnosed with lung cancer are former smokers who heeded the call to quit, and 20% never smoked at all. That changes the conversation about lung cancer. There's a lot of blame, shame, and stigma associated with this disease unfairly. And I don't care if you smoke 500 packs of cigarettes a day, no one deserves to die from lung cancer. And so there needs to be more research and attention on this disease, that the way that there has been on other diseases. I used to run the Washington office for the Susan G. Komen Foundation. And one of the things I always remind people of in our office is I worked for sort of the grand dame of the cancers. Members of Congress would call me. When I got to Lung Cancer Alliance, I couldn't get like an intern to return a phone call. That's changed, though, in the way that the doctors talked about the research exploding now. Now it's, when I call and I say I'm from Lung Cancer Alliance, we actually get our phone calls returned and people care. And we think a lot of that is because of the stories around lung cancer screening. I don't know how, this was the thing that caused me the most stress in making this PowerPoint, was like how to make these like little questions work. So my question was, what percentages of lung cancers are diagnosed early stage? And I don't know how to make that work. So do you press a button or? Okay. Is something going to show up on here? Okay. I don't think it's nothing. Okay, what's the answer? Who knows? Want to yell it out? It's A. And the reason why I always want to point out how few lung cancers are diagnosed early stage is because that number is directly attributable to survival rates. The earlier you can detect any cancer, the more likely you are to find survivors. And in lung cancer, the survival rates were, I don't know, what does that say? Maybe it is doing something. Hey, technology. No, it's not doing anything. The story of lung cancer, the reason that survival rates are so dismal is because of this 15% number. This story can change, and the significance of lung cancer screening is that it can change the trajectory of this disease. The reason why lung cancer is such a devastating diagnosis is because so many people are diagnosed late stage. The earlier we can diagnose lung cancer, the more likely we can find ways to treat it, cure it, minimally invasive surgery. If you find lung cancer early, you can remove it with minimally invasive surgery, often without chemotherapy or radiation. And even at later stage, you have higher survival rates. The incredible work that's being done with targeted therapy and immunotherapy is going to make more and more survivors. We have an annual advocacy conference in Washington, and every year we see people who have survived a lung cancer diagnosis and late stage diagnoses for like 10, 15 years. My colleague at Lung Cancer Alliance, Sheila Ross, is a 2-time late stage lung cancer survivor. She's 15 years out, and she's not going anywhere. So, and that's such an inspiring story because survivors also give us an army that this cancer can't be ignored. This is actually the timeline on what's going on with lung cancer screening. And so what I do at Lung Cancer Alliance is fight for coverage. And so way back, we were fighting for insurance coverage. Insurance coverage was dependent upon the USPSTF recommendation. Once the USPSTF recommendation came through, all insurance plans will have to cover lung cancer screening by this time next year. It's important to know that there are many insurance plans that are already covering lung cancer screening. Excellus Blue Cross Blue Shield, Empire may be doing it. Some of the big New York plans have actually adopted medical policies, and they adopted them 2 years ago. They may not be talking about them, but they adopted medical policies to cover lung cancer screening. And a lot of that was based on the NLST. And so right after the NLST trial, WellPoint started covering it, which is Anthem Blue Cross Blue Shield. After the USPSTF recommendations came out making it an essential health benefit, many Blue Cross Blue Shield plans are covering it. Aetna has adopted a policy nationally, and we're working on Humana and others. The last piece of the puzzle is the Medicare piece. I was at the MedCAC hearing, and so I was like screaming earlier today thinking about how it was portrayed. It's important to know that the MedCAC hearing that happens at the Centers for Medicaid Services are merely advisory committee hearing. It's merely an advisory meeting. They could say anything they want. It's completely non-binding. The meeting was one of the most stunning episodes of my career in terms of sort of bias and one-sidedness of it. And so it was no surprise, frankly, from the questions that they had sent out in advance. We knew exactly what the recommendation was going to be from the MedCAC meeting. MedCAC meeting is behind us. Any day now, and I talked to CMS yesterday, any day now, Medicare is going to issue its draft decision on whether or not it's going to cover lung cancer screening for the USPSTF recommendation. It has to do it by next Monday. It could do it tonight at 4 o'clock. Everybody's out of the office today, so we're betting today at 4 o'clock because we're not there to do anything about it. That decision will likely result in some type of coverage. And the reason we think that, and I'm going to skip a bunch of slides because everybody talked about screening. When the USPSTF made the decision that lung cancer screening was a essential health benefit for people between 55 and 80 with a significant smoking history, that decision only applied to private insurers. It only compelled private insurance plans to cover lung cancer screening. Medicare has to make a decision on whether or not it's recommended and necessary for the Medicare population. If you look at this chart, you can see that the median age of diagnosis is 70, and the majority of cases of lung cancer are diagnosed in the Medicare population. We assumed that would be game, set, match. It wasn't. But we think that it will be very difficult for Medicare to not cover lung cancer screening. So there are actually 4 possibilities that could happen by Monday. They could say no coverage, which we think is politically impossible in light of the USPSTF recommendation and the Affordable Care Act. I mean, it cannot be an essential health benefit for some and not an essential health benefit for the highest risk population. I would take that one to the bank if they tried. We also don't think that they can give full, just unrestricted coverage. And the reason for that is because of all the fear-mongering and the concerns that have been raised. And it's not that the concerns are not legitimate, it's that the questions have been asked and answered. There's no question about radiation dosage. There's no question about false positive. There's no question about anxiety that has not already been looked at. NLST looked at it, USPSTF looked at it. It's not new. And these two, the NLST, largest cancer trial in the world, I didn't know you'd ever use that description of it, which was fabulous. And USPSTF, which is the agency charged by the federal government to decide objectively and without bias what types of services should be covered, they looked at it for more than 2 years. And so to continue to bring these up, issues as if they're new issues, for us feel like nothing more than fear-mongering. There are always risks associated. There will always be risk associated with the follow-up care of lung cancer, screening. You don't want to do unnecessarily invasive treatments, absolutely. But to say that we need more evidence, which is our biggest concern, is that what CMS will say is that we need coverage with additional evidence development. What that will mean is that we basically have to run a whole new clinical trial just on the Medicare population, and we don't think that's reasonable. It's true that it was only a small percentage of the 53,000 people in the NLST who were in the Medicare population, but that was 14,000 people. And 14,000 people in and of itself is a very large clinical trial. And so to say we don't have enough information about how lung cancer screening works in the Medicare population we don't think can be justified. What we do know is this, is that an unprecedented group of leaders in the field, including the American College of Radiology, oncologists, thoracic surgeons, lung cancer organizations like Lung Cancer Alliance, the American Cancer Society, over 100 organizations came forward and said to Medicare, this is the responsible path forward for lung cancer screening. We, of all people, don't want anyone sort of irresponsibly subjected to lung cancer screening and the dangers of the follow-up care. And so the provisions that were put forward said that we're going to screen only the highest risk patients. There are two known proven high-risk categories, 55 to 80 with a 30-pack-year smoking history, and then there's a second group that are the 50-year-olds with a 20-pack-year smoking history and who have other risk factors. Unfortunately, the USPSTF recommendation only talks about the highest risk group. But if we screen the right patients in the right equipments that use the best equipment and have trained physicians and follow the best practices for managing the nodules, every nodule you see, and you've heard that before, is not lung cancer. And so there are protocols that are in place that are being developed and refined every day that are improving the way that we're managing the nodules and the follow-up care that comes with the nodules. The other very important thing is the collection of data. What lung cancer screening is going to do is open a window that we have never had on lung cancer. We know very little about the natural evolution of lung cancer. Most lung cancers are diagnosed late stage. Sometimes accidentally we'll catch them early stage, 15%. With lung cancer screening, we're going to start to see more about the whole story of lung cancer. And from that information, we're going to be able to make progress into ways to treat and even cure lung cancers that we don't have now. And so we don't need Medicare to tell us that we need to collect data and report it. We put forward to Medicare, and we want to come together and report data. LungGrads is actually done. Yay! ACR rushed through a way to make sure that there was a reporting mechanism in place that CMS was comfortable with, in the way that they're comfortable with BI-RADS and for mammography. So we've given Medicare all the tools that they need. We have given them the pathway forward, and we are doing. Okay, I'm Catholic, so I do novenas. We are doing all the things that we need to do to try to get some help and try to make sure that lung cancer screening is covered. This is our organization, Lung Cancer Alliance, long ago came forward with a pathway to responsible care. This screening center at NYU is one of our screening centers of excellence. There are other screening centers of excellence in New York, but we're very proud of that NYU has received the designation of a lung cancer screening center of excellence. Importantly, because one of the allegations is that lung cancer screening will tell people you can continue to smoke. If you present and you come and you say that you want lung cancer screening and you still smoke, what lung cancer screening centers of excellence do is they ensure that you have smoking cessation counseling. And it's very important. And what we have found, and there's peer-reviewed data that is actually going to be released at APHA, what we have found is that that type of smoking cessation counseling that happens within the context of lung cancer screening has even more successful quit rates than other cessation programs. We have over 250 lung cancer screening centers of excellence across the country. What was so inspiring about today was to hear everything about immunotherapy and targeted therapies and all of those things. And so one of the slides showed how are we going to make the connection between what we're finding out through screening and what we're finding out through other methods of detecting lung cancer early and treating it. There's very promising work being done with breath, sputum, blood tests, molecular tests to find ways to detect lung cancer early. But we can actually work together and validate through what we're finding through screening and align that with what we're finding out through biomarkers and other research, and eventually find a path forward for a way to screen everyone at risk for lung cancer, whether they're former smokers, whatever the risk factors are. And that will be when we get to the point where lung cancer screening is actually an opportunity to help not just those who develop lung cancer because of a smoking history, but those who with all forms of lung cancer, including those many, many people, 3 to 1 women to men who develop lung cancer who never smoked at all. Sorry to rush through, but a lot of what I had in my deck got covered. So thank you for everything you all do at NYU every day, and Godspeed to all the patients. Thank you.